A pharmacy generates on average more than $5 million in revenue every year. You'll find one on the corner of almost every town in America. People walk in sick and walk out with the medication they need. Pharmacists are consistently ranked among the most trusted professionals in the country, often scoring higher than doctors, bankers, and almost every other profession. From the outside, owning a pharmacy looks like one of the safest businesses imaginable. People will always get sick. Prescriptions will always need filling. The building is relatively small, the staff is lean, and the product seems to sell itself. But almost everything about that picture is wrong, because behind the counter is one of the strangest business models in American healthcare. The average independent pharmacy generated around $5 million in sales during 2023. On paper, that sounds like a fantastic business, but revenue and profit are two very different things. And in pharmacy, the gap between those two numbers has become enormous. Gross profit margins for independent pharmacies fell to just 19.7% in 2023, the lowest level recorded in the NCPA's 10-year survey. That means for every dollar a pharmacy receives, roughly 80 cents immediately goes toward paying for the medication itself. The remaining 20 cents has to cover everything else: the pharmacist, technicians, rent, insurance, software, utilities, regulatory compliance, and every other expense required to keep the doors open. Then the economics become even stranger. By 2024, the average cost of dispensing a single prescription had risen to around $15. In many cases, the pharmacy isn't even reimbursed that much. Think about what that means. A pharmacy fills the prescription, hands it to the patient, and loses money on the transaction. This isn't a rare exception. It's happening across the country. In North Dakota, one independent pharmacy purchased 60 tablets of an ADHD medication for $164.69. The pharmacy benefit manager, the company responsible for determining reimbursement, paid back just $60.94, plus a 75-cent dispensing fee. The pharmacy lost more than $100 on a single prescription. Similar stories have appeared across the country. A pharmacy in South Carolina lost more than $100 on a blood pressure medication. Another pharmacy in Minnesota dispensed Ozempic, one of the most in-demand drugs in the world, and still lost money on the sale. Which raises an obvious question: why would any business continue selling products for less than they cost?
The answer is that they don't really agree. They comply. And the system that forces that compliance is controlled by an industry most patients have never even heard of. They're called pharmacy benefit managers, or PBMs. These companies are the invisible architects of pharmacy economics. 3 companies dominate the industry: CVS Caremark, Express Scripts, owned by Cigna, and Optum Rx, owned by United Health Group. Together, they process roughly 80% of all prescriptions in the United States. Originally, their job was simple: negotiate lower drug prices on behalf of insurance companies and employers. In theory, they were supposed to reduce healthcare costs. But over the last 2 decades, their role has changed dramatically. Today, they decide which drugs get covered, which pharmacies are included in their networks, and perhaps most importantly, how much those pharmacies get paid for every prescription they fill. That's where the economics become genuinely strange. Each of these 3 PBMs is owned by a corporation that also owns its own pharmacies. CVS Caremark is part of CVS Health, which operates roughly 9,000 retail pharmacies, along with one of the largest mail-order pharmacy businesses in the country. Optum Rx is owned by United Health, which also operates its own pharmacy services. Express Scripts owns Accredo, one of America's largest specialty pharmacies. Think about what that means. The company deciding how much an independent pharmacy gets paid is often owned by the exact same company that owns one of the pharmacy's biggest competitors. The referee is also playing the game. That conflict of interest shapes almost everything. PBMs use a system known as spread pricing. They charge the insurance company one price for a medication, pay the pharmacy a lower amount, and keep the difference. The pharmacy never sees what the insurer paid, it only sees what it receives. And more often than ever, that reimbursement doesn't even cover what the pharmacy bought the drug for. A 2024 interim report from the Federal Trade Commission found that the three largest PBMs marked up certain specialty generic drugs by more than 1,000%. The report described a system where PBMs could increase costs for insurers while at the same time squeezing the pharmacies that actually dispense the medication. But even that is only part of the story, because the reimbursement a pharmacy receives today isn't necessarily the money it gets to keep.
But the reimbursement at the point of sale is only the part of the problem. There's a second mechanism that makes pharmacy accounting feel more like a guessing game. They're called DIR fees, direct and indirect remuneration. Originally, these fees were created under Medicare Part D as a way to track price concessions throughout the system. In practice, they've become a way for pharmacy benefit managers to claw back money from pharmacies, weeks or even months after a prescription has already been filled. Imagine filling a prescription in January. At first, it looks profitable. The numbers seem to work. But then March arrives, and a performance-based DIR fee wipes out that profit. Sometimes, it even turns the prescription into a loss. According to the NCPA, the average independent pharmacy pays well over $100,000 every year in DIR fees. These fees are often tied to quality metrics, including star ratings that were originally designed to evaluate insurance plans, not pharmacies. And the targets don't always stay the same. A pharmacy can meet every benchmark one quarter and still pay higher fees the next, simply because the performance curve shifted. Think about what that means for the owner. On the day a prescription is filled, they often have no way of knowing whether it will actually make money or lose it. That uncertainty doesn't affect one prescription, it affects tens of thousands. Many independent pharmacies fill around 60,000 prescriptions every year. When every one of those transactions carries uncertain profitability, financial planning becomes almost impossible. And that's when the real chain reaction begins. As reimbursements continue falling below the actual cost of the medication, cash flow tightens. Hiring another pharmacist becomes difficult. Adding technicians becomes harder. Wait times grow longer. Patients become frustrated. Some decide to transfer their prescriptions to the CVS or Walgreens down the street. Those companies can absorb losses on individual prescriptions because their parent companies earn profits elsewhere in the supply chain. Independent pharmacies can't. As prescription volume falls, their negotiating power with wholesalers weakens. Drug acquisition costs rise. Reimbursements stay low. Margins shrink even further. Higher costs, lower reimbursements, fewer patients. The cycle feeds itself. And for many pharmacies, there's only one possible outcome. More than one independent pharmacy closed every single day across the United States during 2023 and 2024. In just 1 year, the number of independent community pharmacies fell from more than 19,400 to fewer than 19,000. Since 2010, roughly 1 in every 3 retail pharmacies in America has disappeared. That trend has created something public health experts now call pharmacy deserts. Communities, often rural, often low income, where the nearest pharmacy is now 10, 20, or even 30 miles away. When a pharmacy closes, a community doesn't just lose a place to collect prescriptions, it loses one of its most accessible healthcare providers. The pharmacist who administered flu shots, checked blood pressure, helped elderly patients manage multiple medications, and answered questions without requiring a doctor's appointment. Research has linked pharmacy closures to lower medication adherence and higher emergency room visits. The effects reach far beyond the business itself. If you want to see what happens when these economics break down at scale, look at Rite Aid. For decades, it was one of the largest pharmacy chains in the United States. Thousands of stores, millions of customers, a nationally recognized brand.
Yet in October 2023, Rite Aid filed for Chapter 11 bankruptcy protection while carrying billions of dollars in debt. The company began closing hundreds of stores. Then, less than 2 years later, it filed for bankruptcy again. By October 2025, every remaining Rite Aid location in the country had closed. More than 60 years of history gone. The reasons were complicated: opioid litigation, heavy debt, operational mistakes, failed acquisitions. But underneath all of those problems was the same economic pressure facing every pharmacy in America. The gap between what pharmacies paid for medication and what they were reimbursed had become too small to sustain the business. Rite Aid didn't fail because people stopped needing prescriptions. It failed because filling prescriptions was no longer enough to keep a pharmacy financially alive. Which raises an even bigger question. If independent pharmacies are losing money and even one of America's largest pharmacy chains couldn't survive, how does any pharmacy stay in business today?
The pharmacies that survive today have effectively reinvented what a pharmacy is. Prescription dispensing is no longer enough. Instead, they've built entirely new sources of revenue. Some specialize in compounding, creating custom medications tailored to individual patients. It's a growing market, especially with demand for compounded GLP-1 treatments. Others partner with hospitals and clinics through the federal 340B program, allowing eligible healthcare organizations to purchase medications at significantly lower prices. That creates margins that traditional prescription dispensing often can't. Many have expanded into clinical services, medication therapy management, immunizations, chronic disease screenings, point-of-care testing. According to the 2024 NCPA Digest, more than 90% of independent pharmacies now provide flu and non-flu vaccinations. More than 80% offer medication therapy management. The reason is simple. These services generate revenue without depending on the pharmacy benefit manager reimbursement system, and that's become the key to survival. The pharmacies that remain successful no longer treat prescription dispensing as the center of the business. Instead, they treat it as the service that brings patients through the door. The prescription creates the relationship. The clinical services create the profit. That's one of the most surprising realities in modern healthcare. The core activity people associate with a pharmacy, filling prescriptions, is often the least profitable part of the business. Sometimes it even loses money. The prescription itself has quietly become the cost of doing business, not the business itself. And once you understand that, the entire industry starts to look completely different. It also raises one final question. If filling prescriptions is no longer the business, what does owning a pharmacy actually look like today? So what does owning a successful pharmacy actually look like today? The best-case scenario isn't a business that depends entirely on filling prescriptions. It's a diversified healthcare practice, one that combines prescription dispensing with clinical services, compounding, immunizations, medication therapy management, and partnerships that generate revenue outside the traditional reimbursement system. Those pharmacies still fill prescriptions, but they no longer rely on prescriptions alone to stay profitable. That's the difference. In the more realistic scenario, an independent pharmacy survives by constantly adapting. The owner watches reimbursement rates, negotiates with wholesalers, manages inventory carefully, expands clinical services, and looks for every opportunity to generate income beyond the prescription counter. It's no longer just about medicine, it's about managing an increasingly complex business. Then there's the worst-case outcome. Reimbursements continue falling. DIR fees continue eroding margins. Prescription volume declines. Patients transfer to larger chains. Cash flow tightens. Eventually, the numbers stop working. The doors close, and another community loses one of its most accessible healthcare providers. That's the reality facing hundreds of pharmacies every year. When most people picture owning a pharmacy, they imagine someone in a white coat standing behind a counter while prescriptions generate a steady stream of income. The reality couldn't be more different. Today, a pharmacy owner operates inside a system where drug costs continue rising, reimbursements continue falling, and fees can be taken back months after a prescription has already been filled. The business that once revolved around selling medicine has become a business focused on surviving everything surrounding the medicine. That's why the pharmacies that succeed today aren't simply better at filling prescriptions. They're better at providing services that the reimbursement system can't easily squeeze. When you step back and look at the economics, one conclusion becomes impossible to ignore. Owning a pharmacy was once about selling medicine. Today, it's about surviving the system that stands between the medicine and the person who needs it.